Harrison's Master Modern Medicine.
Aortic regurgitation is one of the most common and serious valvular problems affecting the heart. This condition arises from insufficient closure of the aortic valve, which causes blood to leak from the aorta into the left ventricle when the ventricle relaxes during diastole and left ventricular pressure falls. In this lecture, we will cover the mechanisms leading to regurgitation and the associated pathophysiologic changes in the heart. Aortic regurgitation typically arises from either scarred and abnormal leaflets or dilation of the aortic root. The most frequent causes of leaflet abnormalities are bicuspid aortic valves, rheumatic carditis, and bacterial endocarditis. On the other hand, aortic root dilatation may cause aortic regurgitation if it is significant enough to prevent the valve leaflets from making contact with each other. The most common causes of aortic root dilatation are poorly controlled hypertension and aneurysms of the ascending aorta, which may also be seen in patients with bicuspid aortic valves. In diastole, the left ventricle relaxes and left ventricular pressures fall. As left ventricular pressures fall below aortic pressure, the leaky valves in patients with aortic regurgitation will allow blood to flow back or regurgitate from the aorta into the left ventricle. This regurgitant volume forces the left ventricle to cope with much higher diastolic filling volumes than normal and imposes a volume load on the left ventricle. This volume load results in a compensatory eccentric hypertrophy, which causes left ventricular dilation and increases the left ventricular end diastolic volume. During this compensatory phase, the left ventricular diastolic volumes are increased, but the systolic function is maintained and end systolic volumes and ejection fraction are normal. Net cardiac output is also maintained because the dilation of the ventricle leads to an increase in stroke volume, which compensates for the regurgitant volume. This compensation may be effective for years or even decades. However, decompensation may eventually develop, which can ultimately lead to heart failure. The increased left ventricular diameter increases wall tension, which can eventually cause myocyte failure, and systolic dysfunction can develop as a result. The systolic dysfunction is characterized by a decreased ejection fraction and increased left ventricular end systolic volume. These changes are associated with further increases in left ventricular end diastolic volume and left ventricular end diastolic pressure. The decreased ejection fraction decreases cardiac output, and the increased left ventricular end diastolic pressure increases pulmonary capillary wedge pressure, and together these cause heart failure. Ischemia is another potential consequence of aortic regurgitation. As blood leaks from the aortic valve back into the left ventricle, the arterial diastolic blood pressure is reduced. This in turn decreases both the coronary arterial filling pressure and the myocardial oxygen supply. Meanwhile, the previously discussed increase in wall tension due to the enlarged left ventricle increases myocardial oxygen demand. This decrease in oxygen supply, but increase in demand, causes myocardial ischemia.